continues to evolve and mutate, let's explore some of the latest findings about how well vaccines work against emerging variants, what global conversations are saying about vaccination strategies, and whether Malaysia can and should adapt to some of these new findings. Let's begin the show with our first guest tonight, Dr. Vinod Balasubramaniam. He's a senior lecturer and co-lead of the Infection and Immunity Research Strength at the Jeffrey Chee School of Medicine and Health Sciences of Monash University, Malaysia. Dr. Vinod, thank you so much for joining us on the show tonight.
Now, thank you so much, Melisa. Thanks for having me.
You're welcome. Yes. I'd like to begin our conversation tonight with news that Malaysia has cut the Estrazenica dosing interval from 12 weeks to 9 weeks. And I want to bring that up because, I've come across a study by Oxford that indicates the shortening of the Estrazenica dosing interval actually might reduce rather than enhance vaccine effectiveness. What they found is, in fact, a 10-month delay between the first and second AstraZeneca dose will actually lead to enhanced immunity response after the second dose. So I'm just wondering whether you can help us understand how dosing intervals make a difference to immunity and antibody response.
Thank you for this question, Melissa. So traditionally, if you look at vaccination, when we speak about vaccination, right, we need 2 doses, right? The first shot or the first dose is known as priming, where we introduce a foreign antigen to our immune system, right? And the second dose after an interval is known as boosting, basically creating, immunologic memory against a particular antigen, basically making antibodies, right? So interval is needed for our cells to recover, to learn, right, to process the antigen, right, and to build, sufficient memory antibodies, right, neutralizing antibodies which are efficient against the particular antigen, be it the spike protein or any other antigen, right? And sufficient interval is needed for our body to recover and to produce the antibody, right? And recent studies have shown that actually delaying the second dose creates twice or thrice as much as neutralizing antibodies when compared to 4 weeks interval. Yeah, so this is something the government should look into and give consideration, because the previous interval was 3 months, somewhere around 12 weeks. And the recent shortening, we were announced of the recent shortening based on, I'm not really sure what was it based on and why it was shortened.
Okay, so if I can just refer to some of the news reports about the reasons for shortening, and part of it seems to be a strategy to deal with the variants. Suggesting that, in fact, people with 2 doses did better against the Delta variant. And so there seems to be a public policy dimension to it, a kind of urgency to get more people with 2 doses, especially those who are vulnerable, rather than stretch out the interval period. That, I believe, is in fact the rationale behind shortening the period. I mean, does that make sense to you from a scientific point of view?
Yeah, I would agree to a certain extent. Now, guys, we must understand that, the vaccines were developed at an unprecedented, time, space, right? Within a year, we got approval. We are still learning how our body mounts response towards all these various vaccines, right? And we are learning every day on how our immune response actually builds defense against COVID-19, right? It's the data we get is real time, right? Every day the data changes, right? And we know that from recent evidence that 2 doses of vaccines are important to give the fullest protection, to teach the body to make antibodies, and also to trigger T cells, which are important to kill cells which are infected, for example, right? But we must also understand, right, variants of concern, right? Variants of concern changes this equation, right? Variants of concerns are COVID-19 variants, which reduces the efficacy, right? Reduces the efficacy, reduces the neutralizing capabilities of antibodies produced by this vaccine.
Right.
Right.
I mean, I completely
yeah.
agree with you, Dr. Vinod, that there's so much information coming out. The virus is evolving so quickly, and what we know of the virus is coming out almost on a daily basis. There's new scientific research coming out on this. I mean, not too long ago we were talking about mixing and matching, or mixing vaccine types, and I'm just wondering, I mean, whether the conversation around the mixing vaccines, or the thinking behind mixing vaccines, are we past that? Is that no longer a conversation that decision makers are thinking about?
Yeah, that's really a good point, and I'm a really I'm a really pro when it comes to mix and matching, judging from the recent phase 2 trials which came out, right? So traditionally we use first dose, second dose of the same brand of the vaccine, right? Basically, you are showing first picture, right? So that our body memorizes the picture, and then you show another picture, similar picture, so that our memory increases, right? Mix and matching, basically, you are using heterologous, two different brands, right? The common ones are the Estrazenica, followed by Pfizer BioNTech. So basically, you are showing same pictures at different angles, right? Different angles. And the data which came out, although the study is limited, the sample numbering is limited, the data is astonishing because the antibody, the protection given, right, is twice as good as, while using vaccines from the same brand, right? Apart from, efficacy against the variants. So yeah, I was really hoping the government would, give consideration on mix and matching, right? Considering the benefits.
But can I just ask you then, what are the disadvantages of mixing vaccine? I know you hope that this is something the government will consider, but what are the real world considerations when it comes to this approach?
First, I would say, because the study is limited, it is still not convincing certain governments, right? Namely Malaysian government, for example. We heard that Khairi saying that, the data is still lacking, right? Because I think the number of participants in the trials were less than 1,000, although the data is astonishing, right? We also know that we also need more information whether mix and matching actually induces long-term immunity. We don't know how long the antibody wanes, or we don't know how long the antibody protects. That's another thing. We also don't know whether mix and matching actually, changes or stops transmission of any strains, namely variants of concern. So these are some of the data which is still lacking. I believe, the third trial is going on, and I believe, we'll get more information very soon.
So, what's very interesting, Vinod, is that there's so much information, as you pointed out, coming out, and it's perhaps premature sometimes for this information to come, because it does excite the public, and maybe it does confuse, public officials and policymakers. So, from a scientific point of view, from a scientist's point of view, giving advice to a politician about policy, considering this is a crisis situation, where is the balance? Where do you say, well, this is enough information to go on considering it's a thing, or should you take a more cautious approach and say, well, we really shouldn't until we get the full picture?
Getting the balance is absolutely hard, and in an ideal situation, of course, we will know, the amount of mortality which is happening in Malaysia, which variant is actually driving mortality, which variant is actually, driving infection, which variant is actually driving reinfection among vaccinated individuals. So these are the some of the consideration we have to look before making certain decisions. But being said that, having said that, you look at certain countries like Germany, you look at certain countries like France, UK, Spain have actually approved mix and matching. For example, even I'm pretty sure you guys heard that Angela Merkel actually took the AstraZeneca followed by Moderna vaccine before the phase 2 trials came out, actually. So, it's a give and take. Yeah. So we need more data to look at the severity of the disease in Malaysia, particularly, and which strain is driving the infection, before making such decisions.
Right. Dr. Vinod, can I get your thoughts on the one-dose vaccine? So we've been talking about, the two-dose, the priming dose and then the booster shot. But can we talk about one-dose vaccines? It's been said that these one-dose vaccines will be used in certain segments of the population, but there are other reports that talk about one-dose vaccines needing a booster shot after 6 months. Can they still be considered one-dose vaccines if they need a booster shot in 6 months?
Yeah. So when we know traditionally vaccines need 2 doses. We know that majority of vaccines, COVID-19 vaccines developed requires 2 doses. And, recently we have heard that vaccines like J&J and CanSino claiming that their one-dose vaccine is actually efficient, giving high efficacy, something similar to the AZ vaccine, Estrazenica vaccine, which requires 2 doses, right? And this is met with skepticism simply because, the platform used to design this one-dose vaccine are actually the same one used in AstraZeneca and Sputnik V, for example, right? So people were skeptical, actually one-dose vaccine, will it really work? But recent data, this is very recent. J&J actually released primary initial data showing that their one-dose vaccine is 70 to 80% efficient. And it is also efficient against variants of concern, as namely the Delta variant, right? So for now, one-dose vaccine seems to be working, right? It is working against variants. It is working as efficient as some of the 2-dose vaccines, right? Plus the advantages, right? And, because of one-dose vaccines are easier to store, number one, you don't require people to return at a set time for a second jab, something which is really hard in, say, rural communities, orang asli population, one vaccine, single visit, cheaper logistics. I think we should go for it.
Yeah,
for
it's
now.
interesting because
For
there's
now,
some,
yeah.
So Vinod, there's some doubt about Castor over CanSino and that choice because it doesn't seem to have had approval with any other major regulatory bodies. And correct me if I'm wrong about that. But I do want to ask you about the choices that the regulatory body in Malaysia has made about. So we have Pfizer, we don't have Moderna that's used in Singapore, for instance, and so on and so forth. Sputnik V, no show as well here. What do you make of this bewildering choice and our decisions or the decisions that have been made on our behalf?
Yeah, it's a tricky question. Number one, if you notice, almost all, now when I say almost all, right, almost all vaccines undergo 3 phases of clinical trials, right? Number one, almost all vaccines are, involved. I'm talking about 40 to 50,000 participants of various ages, various setting, racial profiles, environment, right? And all vaccines undergo phase 1, 2, 3, right? Looking at efficacy in COVID, non-COVID patients. And almost all vaccines have their data published in prestigious journals which, change ideas about mankind, right? They're talking about New England Journal of Medicine, Lancet, and, Nature, for example. And sometimes it's frustrating for our NPRA to actually, take longer time to approve certain vaccines when it's approved worldwide, right? For example, we took some time to even approve Pfizer, right? So I think that is something we can work on, right?
Okay, well, Dr. Vinod, thank you for joining us on the show tonight. That was Dr. Vinod Balasubramaniam from the Jeffrey Chee School of Medicine and Health Sciences at Monash University, Malaysia. We're going to take a quick break here on Consider This, but more on the discussion about the new developments of vaccines and variants. That's just in a couple of minutes, so stay tuned. We'll be right back.
Jayden Sancho. Lelaki ni perasan dia tahu semuanya pasal tim England.
Come on England, come on Jayden.
Jayden cannot start today, not fit.
Hi, thank you so much for staying with Sharaad and I on Consider This. But if you've just joined us on the show tonight, we're discussing the latest developments in the science behind vaccines and variants. Professor Dr. Victor Ho Chee Abdullah joins us on the show now. He's the head of Social and Preventive Medicine at University Malaysia's Faculty of Medicine. Dr. Victor, good evening. Thank you for joining us on the show tonight. I'd like to begin with a broad assessment. Your assessment of Malaysia's COVID-19 vaccination strategy as a whole, especially when we take into account the data that is ever evolving about vaccine efficacy against variants of concern, particularly the Delta variant.
Sorry. Basically, the current vaccination policy and basically for phase 1, phase 2, and phase 3 are basically designed to cater for the certain group of people. Like the first phase 1 is healthcare worker, and phase 2 is basically people with vulnerable. And I think a lot of people actually have completed the second dose vaccine. There's around 8% second dose vaccine, and around 15% has completed their first dose of vaccine. So having completed 2 doses of vaccine, you would have reduced the chances of getting severe diseases. Like you only get, if you get COVID-19 disease, you only get category 1 and category 2. But there are also reduced chances of getting diseases. So basically, around less than 10% actually of the people who are vaccinated, less than 1% of people vaccinated actually get the disease. Because we have seen this issue in the University Malaysia Medical Center, where basically we have vaccinated quite a number of our population, around 10,000, and we only get less than 200 cases.
Victor, if I can ask you about the kind of the balance for public policy decision makers between the idea of protecting the most vulnerable as quickly as possible, giving them the 2 doses, prioritizing that, as opposed to giving as many people as possible at least 1 dose. In terms of that debate, where do you stand?
I think the best is to give, because currently we must look at what are the issues that's facing the country now. The issues that's facing the country now is basically lack of our healthcare facilities are actually overwhelmed, and healthcare facilities are overwhelmed basically due to people who is already very vulnerable. All right, so people who are vulnerable would basically develop more severe diseases. So if we can vaccinate the vulnerable people first, and then basically we would reduce the burden to the health facilities that we have now. So for my stake is basically to vaccinate the more of the vulnerable population, because we understand from the current basically the development that even though if you vaccinate only 1 dose of vaccine, all right, the protection against the Delta variant is basically lower. And having only 2 doses, you have a full protection against the Delta variant.
All right. So you are for having 2 doses. And what do you make of the dosing interval? Because again, Malaysia has chosen to reduce the gap of the dosing interval, bringing it from 12 weeks to 9 weeks. And we know, and there's been recent studies that say, well, actually, if you prolong the gap between a dosing, that you might in fact increase the immunity response. But do you think we've done the right thing in making the dosing intervals shorter?
Basically, the research actually come out is that their studies compare between 6 weeks and 12 weeks. And the difference is basically 6 weeks you get around 55% and 12 weeks you get around 80% efficacy. So if the government is going to reduce to 9 weeks, those are the recommended dosing interval by international, even in the UK. Basically, they recommend between 8 to 12 weeks interval between the doses. So it all depends on the availability of the dose, and also it depends on how many people you want to get vaccinated quickly. So by giving the second dose at 9 weeks, I don't think there should be a problem, because other countries also are giving it at 8 to 12 weeks. But of course, the longer you wait, you might have more immunity. But as we mentioned, if we can give 2 doses to as many people as possible, then we will get more people basically getting less severe disease if they get infected.
So, Dr. Vickers, of this issue of the reduced dosing interval applies to AstraZeneca. It does not apply to some of the other vaccines that are in play in Malaysia, right? Pfizer have a fairly short interval. I think 3 weeks is what is recommended.
No. Basically only apply to AstraZeneca. Are we talking about AstraZeneca?
It does only apply. That's right.
Yeah, because AstraZeneca is the one that have the longest. Sorry.
Yeah, well, that's fine. I just want to clarify that. I want to ask you about this recent decision by Singapore to recategorize Sinovac as a less efficacious vaccine in terms of transmission, not in terms of infection or in terms of severity of disease, but in terms of transmission. And they seem to have taken the decision to now have a tiered access for people who've been vaccinated. So if you're vaccinated with Sinovac, you still have to get tested, so on and so forth, unlike somebody who's taken Moderna or Pfizer. Do you think that's actually fair? Do you think, what are the public policy implications of a government taking that kind of a strategy?
I think unless we have enough research to actually shows that it basically does not stop transmission, then only we should make the policy. But currently the research is that all the vaccines actually basically approved by the WHO are efficacious to actually prevent severe diseases. The main thing is that if everybody get vaccinated as quickly as possible, and if we get more people vaccinated, there'll be less chances of the virus basically infecting our population, because most of the people are vaccinated, and those that get vaccinated, they will basically have a lower. Although they get infected, the category of diseases will be lower. That means they're not less severe compared to those that are not vaccinated, and that would basically reduce the burden to our healthcare system.
But Dr. Victor, the issue in Singapore is not so much about that. It's not about the severity. It's not about the infection rate. It's about transmission. The finding now that the mRNA vaccines, Pfizer vaccine, actually is efficacious in reducing transmission of the virus, and therefore because of the high efficacy of 90% efficacy. So when you're 90% efficacy, so when everybody get vaccinated, then the transmission basically would reduce. But not just basically, although you say the Pfizer does not lead to transmission, but the study is still very new, because the vaccine itself is very new. And I don't think we have enough information to say that the Sinovac is basically less efficacious in stopping transmission compared to other vaccines. The main thing is if we start to give more information to the public, and then it's very difficult for people to actually decide on what vaccine to take. This is the first time in our history that we are given a choice of what type of vaccine to take. Before this, basically, there's no choice of what vaccine to take. You just go to a doctor, and doctor will give you whatever vaccine is there, and you just take it.
Right. Yeah, I completely agree with you. I mean, the public is kind of bombarded with news that seems to shift on not just a weekly basis, but now a daily basis. And I feel for policymakers who have to think about or take into or negotiate some of that news into the decision making. I just want to ask you very quickly, because you talked about getting as much of the population vaccinated as possible. And I know that there's still a pillar in our pandemic management strategy. But Khairi Jamaluddin has said recently he stopped using the term herd immunity, and he's talking about an endemic COVID-19. I'm just wondering what your thoughts are on herd immunity, if that's no longer possible, and whether the vaccines are still winning the fight against variants.
The main thing is that vaccine are still winning the fight against the variant, but we are not here to stop what we call it. We're not here to stop the disease, stop you from getting the disease. It's more important than stop you from getting very severe diseases. Even most of the vaccine that we are getting now doesn't stop you from getting the disease. It basically stops you from getting severe diseases. And because you have less severe diseases, you have less chances of passing the virus to other people also. And you also less chances of basically landing up in hospital or landing up in the morgue. So that is the most important part of it. I know, I understand that a lot of people are talking about the disease. COVID-19 is going to be endemic. Yes, COVID-19 is going to be endemic. But even if it's endemic, we can still try and reduce the endemicity by vaccinating as many people as possible. The thing is that what we need to do now is we need to focus on vaccinating as many people as possible. As we see in many countries, like in the US and the UK, life basically have returned to normal, almost normal, because they have vaccinated enough people, around 60% of their population. So if we can reach that stage, and basically we will be able to achieve at least some type of normality in our life. Currently, we are only around 15%.
Thank you so much. That was Dr. Victor Ho from University Malaya's Faculty of Medicine. That's all we have for you on this episode of Consider This. Thank you so much for watching the show. I'm Melisa Idris.
And I'm Sharaad Kuttan, signing off for the evening.
Have a lovely weekend. We'll see you on Monday. Till then, good night.